Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 348 of our pharmacotherapy series, which majors in dosing of drugs in renal failure. The next case reads, JJM, a 24-year-old man with end-stage renal disease, is maintained with CAPD. He presents to the emergency department with a fever of 38.2 degrees Celsius and complains of severe abdominal pain. He also reports that his peritoneal dialysate has become cloudy in the past few days. All these symptoms are consistent with peritonitis, a frequent complication of CAPD. His culture results reveal Escherichia coli, sensitive to gentamicin. So my question to you is, how should gentamicin be dosed in this patient? Management of dialysis-related peritonitis can vary from one institution to another. Antibiotics often are administered intraperitoneally with or without systemic antibiotic therapy. For less severe cases, intraperitoneal administration is often considered sufficient. With intraperitoneal administration, the goal is to deliver a concentration of drug similar to the desired plasma concentration for the treatment of systemic infections. Therefore, 8 mg of gentamicin into each liter of dialysate, or 16 mg into a 2-liter bag of dialysate, is recommended. Once equilibrium or steady state is achieved, the dialysate concentration will be comparable to the concentration of gentamicin in the plasma. Despite a more rapid transfer of drug into the plasma because of increased permeability of the peritoneal membrane in patients with peritonitis, there will still be a substantial lag time before steady state is reached. For more serious cases of peritonitis, concomitant systemic antibiotics should be given. My next question to you reads, is gentamicin eliminated by continuous ambulatory peritoneal dialysis? In general, most drugs are not well removed via continuous ambulatory peritoneal dialysis. This is particularly true for drugs that are highly protein-bound or for drugs with a large volume of distribution. Gentamicin and other aminoglycosides, on the other hand, are effectively removed by continuous ambulatory peritoneal dialysis, because they have low protein binding and a small volume of distribution. It is estimated that 10% to 50% of gentamicin is removed by continuous ambulatory peritoneal dialysis. The next case reads, DOM, a 28-year-old man with acquired immune deficiency syndrome, presents with a severe herpetic infection requiring IV acyclovir. Because of other complications associated with his human immunodeficiency virus, HIV, infection, DOM has developed renal insufficiency during his hospital course. His serum creatinine is 4.5 mg per deciliter, and his creatinine clearance is 20 ml per minute. So my question to you is, what are important considerations for dosing acyclovir in DOM now, and also if he requires dialysis? Acyclovir is used to prevent or treat a variety of viral infections, such as those caused by herpes simplex and varicella zoster viruses. It is cleared primarily by the kidneys, with approximately 70% to 80% excreted unchanged in the urine. Dosage adjustment is necessary in patients with renal disease. Renal tubular secretion in addition to filtration contributes to the elimination of acyclovir, which explains why the renal clearance of acyclovir is about 3 times greater than the estimated creatinine clearance. Acyclovir also can precipitate in the renal tubules and exacerbate DOM's renal failure. This is more likely to occur when high doses are infused too rapidly to patients with renal dysfunction. To minimize nephrotoxicity, the patient should be adequately hydrated to maintain good urine flow, and the acyclovir dose should be infused over the course of 1 hour. Nephrotoxicity is usually reversible on discontinuation of the drug or reduction of the dose. In addition, acyclovir-associated neurotoxicity correlates with elevated plasma concentrations, and further underscores the need for adequate dosage adjustments in patients with renal dysfunction. The clearance of acyclovir correlates with the creatinine clearance according to the following relationship: Cl for acyclovir is equal to 3.4 multiplied by creatinine clearance all plus 28.7. In patients with normal renal function, the clearance of acyclovir ranges from 210 to 330 ml per minute. In patients with end-stage renal disease, the clearance is 29 to 34 ml per minute. Although this change in clearance primarily results from decreased renal clearance of the drug, non-renal clearance of acyclovir also decreases in these patients. As a result, the elimination half-life increases significantly from approximately 3 hours in patients with normal kidney function to 20 hours in patients with end-stage renal disease. Therefore, doses should be reduced proportionately from a normal daily dose of 15 mg per kilogram body weight, 5 mg per kilogram given every 8 hours, for serious herpes simplex infections to doses as low as 2.5 mg per kilogram per day, given as a single daily dose, in patients with end-stage renal disease. Because DOM has a creatinine clearance of 20 ml per minute and an estimated Cl acyclovir of 97 ml per minute, approximately 1/3 of normal, a single daily dose of 5 mg per kilogram, 1/3 of normal, would be appropriate to treat this infection. Let's now look at dialysis. Acyclovir is moderately removed by conventional hemodialysis, with plasma concentrations decreasing by 60% after 6 hours of dialysis. The elimination half-life on and off dialysis is 6 and 20 hours, respectively, whereas the dialysis clearance averages 80 ml per minute. Therefore, a supplemental dose of 2.5 mg per kilogram after dialysis is recommended to replace the amount of drug removed by hemodialysis. No data are available on the removal of acyclovir by high-flux hemodialysis. My next question to you reads, does DOM's renal dysfunction affect the metabolism of acyclovir? Are there other drugs that are affected similarly? Approximately 20% of acyclovir is cleared by non-renal mechanisms. The only significant metabolite that has been isolated is 9-carboxymethoxy-methylguanine, which accounts for 9% to 14% of an administered dose. It is believed that this metabolite is a product of hepatic metabolism. However, the kidney may also play an important role. 19 Whether renal dysfunction alters hepatic metabolism or metabolic enzymes are present within the kidney is unclear. Renal tissue contains many of the same metabolic enzymes found in the liver. Mixed function oxidases have been found in segments of the proximal tubule, whereas other metabolic processes, such as glucuronidation, acetylation, and hydrolysis, also occur within the kidney. Renal failure can affect hepatic metabolic enzyme activity and drug transporter function. Most of these investigations were carried out in animals that had diminished microsomal, mitochondrial, and cytosolic enzyme activities. Renal dysfunction substantially alters the non-renal clearance of certain antibiotics, such as ceftazocime, cefotaxime, and imipenem, as well as the benzodiazepines, diazepam and desmethyldiazepam. My next question to you reads, DOM also is being treated with tenofovir as part of antiretroviral regimen for his HIV disease. Will his tenofovir doses need to be adjusted? Let's briefly look at dosage adjustment. Tenofovir is a nucleotide analog of adenosine monophosphate. Tenofovir undergoes activation by phosphorylation to the active form, tenofovir diphosphate. Tenofovir diphosphate inactivates HIV reverse transcriptase and HBV DNA polymerase by causing chain termination. It is used as part of an antiretroviral regimen in the treatment of HIV infection and can also be used for the treatment of chronic hepatitis B infection. Approximately 70% to 80% of tenofovir is excreted unchanged in the urine. The elimination half-life is approximately 17 hours, and the clearance is significantly reduced in the setting of renal dysfunction. Nephrotoxicity, including cases of acute renal failure and Fanconi syndrome, renal tubular injury and hypophosphatemia, have been reported. Organic transporters in the proximal tubule are believed to mediate nephrotoxicity. The dose of tenofovir must be adjusted in the setting of kidney dysfunction to prevent accumulation, and the potential to worsen renal dysfunction. Tenofovir is also available in combination with other antiretrovirals in a single-dose formulation for the treatment of HIV infection. The specific dosing recommendation should be consulted in the setting of renal dysfunction for tenofovir or the combination products. My next question to you reads, is tenofovir significantly removed by dialysis? Tenofovir is effectively removed by hemodialysis, with an extraction coefficient of approximately 54%. Approximately 10% of a 300 mg tenofovir dose is removed after 4 hours of hemodialysis. The recommended dose of tenofovir is 300 mg orally every 7 days, after approximately 12 hours of hemodialysis or 3 4-hour dialysis sessions. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 349.